welcome everyone to our final webinar of the year, hosted by Sadiq International University and IMI, Imamiya Medics International. Welcome to everyone, including our speaker, Dr. Naveed Yusuf. And before I hand it off to our moderator, Dr. Tabassum Zehra, I'd just like to invite all of you to stay till the end for a special presentation by our Chancellor of Sadiq International University, Dr. Shabi Zaidi. So please take it away, Dr. Tabassum.
Thank you so much, Ipa. I would like to introduce Dr. Naveed Yusuf, who is presenting today, and the title of but before introducing the title, I would like to introduce him. He is assistant professor at Department for Education Development, Akhan University, and he is also associate director at Akhan University Examination Board. He's chairing the Graduate Admissions Committee at Akhan University Faculty of Health Sciences, chairing the Undergraduate Medical Education Assessment Review Committee. He has obtained a PhD in medical education with specialization in assessment psychometrics in 2014 from Italy. And he leads quality assurance, psychometrics, and research for Akhan Examination Board, National High Stakes Assessment. And he is also involved internationally. He has developed competency-based model on 21st century skills and outcomes-based assessment for examination board students. He's a faculty who is involved in Master of High Professions Education program at Akhan University as well, and he is supervising many of our thesis of our students. He's also the advisor of psychometrics for the MRCGP International, South Asia, and a member International Association for Educational Assessment for developing international assessment standards. He has over 15 years of teaching and faculty development experience. His experience and interest is related in curriculum development, assessment, educational research, and leadership in HPE. Sorry. So we welcome you, Dr. Naveed Yusuf, and we would like you to please share your screen, and so that you will be able to share your title as well. However, his title is Enhancing the Validity and Reliability of Decisions, Objective Structured Clinical Examinations. So over to Dr. Naveed Yusuf.
Thank you so much, Dr. Tabassum Zehra. Thank you for the introduction. And I would also like to thank the Al Sadiq Virtual International University, the Chancellor and the team for giving me this opportunity to present and share my thoughts on this very important topic. The title of the presentation today is Enhancing the Validity and Reliability of Decisions on Objective Structured Clinical Examinations. So the objectives are that by the end of this session, we will be able to design a valid objective structured clinical examination based on the desired outcomes and objectives, and ensure the validity, reliability, and fairness of decisions based on these examinations. The outline is that we will very briefly talk about some important and relevant assessment principles to OSCEs. And then we will, of course, talk about how can we ensure and enhance the validity and reliability of decisions. And I have tried to organize my presentation, what we can do before the OSCE occurs, before we administer the OSCE examination, and then what we can do after the OSCE examination to enhance the validity and reliability of our results and, of course, of our decisions. So let us first talk about some very basic assessment principles and basics of OSCE. I'm sure we all are aware of these principles, the good characteristics of assessments. The first one is validity. And validity of a test is the extent to which the test measures what is supposed to be measured. Alignment with the intended outcomes, learning objectives, curricula, syllabi, and so on. And representative of the learning objectives, skills, outcomes, syllabi, and curriculum. Then we talk of reliability of scores. And that is, score on a test should indicate score on other similar tests. which means that the scores should be reliable, they should be dependable, they should be accurate and precise. Objectivity. Objectivity simply is opposite to subjectivity or biasness. And we can ensure objectivity by making sure that the scoring criteria is clearly laid out, is clearly determined, and agreed upon by content experts, and clearly understood by exam developers, by examiners, and so on. And then there are standardization. And standardization would mean that similar examination, similar content and skills, similar conditions, and similar difficulty for all candidates. Let's recap OSCE. An OSCE station typically involves interaction between a simulated or a real patient, maybe a mannequin, a task, which is the station task, student or candidate, and the examiner. So there are various stakeholders, various players, various variables involved in an OSCE station and in an OSCE examination. And an ideal assessment is, and the aim of assessment is to measure the performance of student, keeping all other variables standardized to minimize the error. So we would like to standardize the behavior of the standardized patient, the behavior of the examiner, and the task should be clearly and similarly understood by all candidates. So whatever we measure, whatever we assess is dependent upon the candidate's performance. And hence, when we see below in the slide, the variables in the OSCE are the simulated or real patient or simulator, the task, the candidate, and this interaction is assessed by the rater, by the examiner or assessor, whatever we call them. And of course, there are other variables, the logistics and the condition, the environment of the examination also play an important role. I would like to brief all this discussion and present this in the form of this simplified diagram. What we want to ensure is that whatever the score, the variance in the score, the shift, the high and low scores are dependent, solely dependent upon the examinee performance, upon the examinee's competence or skills they demonstrate. And for this to happen, we need to keep all others similar and standardized. Suppose if there are two examiners, one for half of the cohort and other for the other half of the cohort, one is a lenient and the other is stringent, one half of the student body will get higher scores because of the lenient examiner, and the other half will get lower scores because of the strict examiner. And as faculty, as an important stakeholder, we know we would not like this to happen. We would like the scores to vary, to move up or down, to go higher or lower, only on the basis of the examinee's skills and what he or she is able to demonstrate during that examination. Similarly, if the patient is not trained enough, is not standardized, and behaves differently with different candidates or examinees, give more information to one and hides information to the other, gets fatigued or tired with time and changes his or her behavior with time with other students, the scores will not only be dependent upon examinee skills and competence, it will also be dependent upon how the patient is behaving with the student. And yes, I know we all are thinking we would not like this to happen. We would like the patients to behave similarly and appropriately with all candidates, and the examinee's performance should be dependent upon his or her own skills and competence. And likewise, the environment, if you have OSCE examination over multiple shifts, multiple days, and the logistics. Commonly, what happens is when the first candidate arrives on the station, there's all the instruments and gadgets are very nicely organized and kept. And when the second or other students would come, probably the organization is lost. There is very little or no time available or no instructions available to the administrative staff or to the examiner present there to then make sure that the uh, instruments and the gadgets are reorganized so that everybody gets an equal opportunity. They don't have to look around for things there. All should get a very similar, equal, and fair opportunity to perform. And that is why it is known as an objective, structured clinical examination. And that's the advantage of OSCE examinations. Likewise, the station task should be clear enough for all candidates to be understood similarly. And then, if we ensure all of this is standardized, the station task is clear enough, and the marking instructions are objective enough, what will happen is that the scores will represent largely the competence or skills of the examinee as demonstrated during that examination. And that is the target. Let's move on further. So what we can do to ensure the validity and reliability before an OSCE examination. The first one is to have a table of specification or an examination's blueprint. An examination blueprint or exam specification, as it is known as, will enable the faculty or exam developers to make sure that the content and skills assessed in the examination are representative of the curriculum, of the syllabus, of the outcomes, or of the learning objectives. Because we know that OSCE examination is case specific. If a candidate or examinee performs well on a cardiovascular system, we cannot predict the examinee will perform similarly in an abdominal system examination or in any other systems examination or history taking. If the candidate performs well on a history taking station, we will not be able to know if the examiner is equally good or not so good in physical examination skills. So that is why adequate sampling and representativeness is very, very important. So one will have to sample across the clinical conditions, the presentations, the patient presentations, or the systems. And one will have also to sample across and ensure representativeness of the tasks, of the skills involved. The example given on the slide is, for example, for the cardiovascular system, you choose chest pain, and then you will have to think what different skills or tasks will you then examine for the chest pain? Will it be history taking, a precordium examination, patient education, counseling, communication, or anything else? And likewise, you will then have to decide on other patient presentations, conditions, problems, or systems, and then what kind of skills will you assess? What are the relevance of these skills and presentations? What is the importance? How common are these in the daily lives of practitioners and physicians in your own context? Maybe one way of determining as to what is more important to keep in the examination as compared to others. I always say, as compared to many other examination methods, OSCE is very resource intensive. It is costly. You need so much of your valuable clinicians or clinical faculty time to be there on those stations to observe and assess your students. You need your real patients trained or your standardized patients there. You need so many stations, logistics, and so on. So it is very, very expensive. And we have to make sure that we utilize this to opportunity to a maximum. We observe, because even during the year, we know we all are busy clinicians and we all struggle to take out time from our clinical responsibilities to observe students, to make sure that they have learned these skills, clinical skills, history taking, physical examination, communication, counseling, and so on. And hence, OSCE is a golden opportunity, I say, to observe students. And you may have a 14 station OSCE or a 16 station OSCE, some more, some less. These are very unique, rare opportunities for you to observe students and assess them and make sure that they have learned these skills. So we have to make sure that whatever we keep on these OSCE stations, whatever tasks we assess the students on, has to be important and relevant. Then we have to also make sure, how do we elaborate upon the tasks, or how do we write down the items which are expected from the candidates or students? Are these clear enough for the examiner to understand, so that the expectations is very clear when the examiner is there and assesses and observes the candidates? Is the task clear again? And then we also have to make sure, if one or a few clinical faculty develops a OSCE station, it has to be reviewed by other team of experts, just to make sure that nothing is left. It is at the level of the candidate. It is what is expected of the candidate. It is aligned to the curriculum, to the outcomes and learning objectives. And doing all this, we can enhance the validity of decisions on OSCEs. This is an example of a blueprint taken from the literature by a chapter by Valerie Voss, a very renowned professor in medical education. And when we see this, there are various different kinds or various different formats of exam blueprints. This is just one example. And you can see that on the leftmost column, the skills are elaborated, they are stated: history taking, physical examination, communication, and clinical procedures. And in the second row, we see all the systems being mentioned, from the cardiovascular system, respiratory, and so on, to the endocrine in the last rightmost column. And then we see what are the different stations being kept in this examination. So it maps out, the blueprint maps out and lets us know as to what will be kept in the examination, and also assess and evaluate if this is a comprehensive examination and if these stations are representative of the skills, of the outcomes, of the learning objectives. I will give you a moment to have a look and review this exam specification. What do you think is good? And what do you think is missing? What are the gaps or limitations in this examination blueprint, and hence in the examination to happen? This is an undergraduate medicine examination. The good point of this format is that it helps you sample across and make sure you are representative of the skills and of the systems. It also helps you write down the clinical problems or presentations, such as heart failure, epilepsy, a diabetic foot. However, as the exam is being planned using this very good format of examination blueprint, one can see that there is overemphasis on the cardiovascular system and the endocrine system, specifically diabetes. And we see abdominal system, respiratory system are very less assessed, just one station on each. And then there are other systems which are completely ignored. We have ignored eyes and ENT and have two stations probably on skin, on dermatology. So is this a very valid exam? Is this exam representative of what is expected of candidates who will just be graduating? Most of us will think, no. We would like to jumble across and make sure that the exam is balanced and representative of all the systems. The systems which are more important should be more representative in the examination. Then comes, once you design and decide on the OSCE stations themselves, you will also then develop or design your marking instrument, your scoring criteria. And what I tell the faculty at the Aga Khan University and at various workshops I do, the first step, just to make the items or tasks or steps expected of the candidates, just to make this step easier, what I advise is to first write down everything that comes to your mind should be assessed, is expected of the student. Once everything is down on the paper or on your screen, on your Word document, you can then review them and see if these are appropriate. If these are appropriate to the level of the learner, this is what you expect from this level of the learner, maybe a year 3 undergraduate candidate, a year 5 undergraduate candidate, a postgraduate candidate. So is it appropriate for them? Is it appropriately phrased to be clearly understood by the examiner? And is it appropriate with regards to the relevance and importance? And is it appropriate to the task which you have written for the OSCE station? Is it aligned to the task which you have written for the candidates? And of course, the task will have to be aligned to the learning objectives. Then of all these steps and tasks you expect from the candidates, which ones are more important than others? What is the weightage? I will give you a very extreme example to understand this concept. I was reviewing OSCE stations, and there was one station on for obstetrics and gynecology, and it was on using forceps to facilitate delivery. All steps written, all tasks expected from the students were of the preparation, wearing gloves, washing hands, and so on. And only the last task or item was the candidate uses forceps appropriately to deliver the child. And all had equal marks or weightage. So even if the candidate could not use the forceps for delivery at all, the student could have passed with extremely good and high scores just based on gloving and preparation and making sure all the gadgets are there. Will that be a valid decision? If the candidate gets honors on that station, gets very high scores, gets a distinction, even without being able to demonstrate a forceps delivery? Surely not. Which means that the items should be weighted appropriately based on the relevance and the importance. And then you will have to decide on the rating scale. We know that a 7-point rating scale is considered as a gold standard with a plus minus 2 points. So any rating scale which ranges from a 5-point to a 9-point rating scale is considered good enough to differentiate well and discriminate well between students. Then comes objectivity. And of course, when we have talked about developing these items or tasks, are these very clearly written for the examiners to understand? Is the rating instrument very clear? Is the scoring criteria is very clearly laid out? So that the scoring and marking criteria is very, very objective. The subjectivity goes out, the examiner subjectivity and bias goes out. And of course, like the stations themselves, the scoring criteria and the scoring sheet will have to be reviewed and pilot tested before we administer that station in a high stakes OSCE examination. How will we ensure reliability before the examination? We know that reliability of the OSCE examination is dependent upon the number of stations and the testing time, just like the reliability of scores of any other assessment method is dependent upon the number of items and testing time. And it is very commonly known that 14 stations to 16 stations is a good number, not only to ensure content representativeness, it is also a good number to ensure reliability of scores on that station. And then the construct of the station, we talked about objectivity. Objectivity also contributes to reliability of scores, to reduce error. We have to make sure that the task is structured, the scoring criteria is objective, the expected performance is very clearly defined, there are use of checklist items and rating scales, and then the standardized patients are trained and they are standardized. They are trained how to behave, what to say, how to respond, what to ask if it is needed, and to behave similarly with all candidates and examinees. If we are using multiple circuits, if you are using multiple shifts or the exam happens over multiple days, we have to ensure that these multiple patients portraying the same case on the same station are trained together, are developed together, briefed together, and standardized to perform very similarly in the examination. And then examiner training and standardization is also very important. The examiner needs to be trained. They need to be described and explain the scoring criteria and make sure they've clearly understood the scoring criteria. And similarly, if we have multiple shifts, multiple circuits, the exam happens over multiple days. And if we are using multiple examiners, they all should be trained together and standardized. So they are behaving similarly and appropriately with all candidates across shifts, across circuits, and across days. This will also ensure intra-rater reliability. So me as an examiner or anyone as an examiner behave similarly with all candidates. An inter-rater, multiple examiners on the same station, performs similarly, scores similarly, gives similar scores to similar level of performance. And of course, students are a very important stakeholder. So students should be briefed specifically when they are very new to objective structured clinical examinations. They should know what is expected, what is this kind of examination, how the logistics work, how will they move from one station to the other, what is the time allocated, where will be the task pasted, what they can expect when they go inside the station. They should be very, very clear. If they are confused, if they are moving other ways, if they are looking for stations and the turns, and if they are not sure what they will expect where the task is pasted, their performance will be affected by irrelevant matters. They will waste their time. And hence the score will then represent other things, other mistakes and errors, rather than their own clinical skills and competence. And hence they should be briefed and very clear as to what is expected on that OSCE examination. We also have to make sure of the fatigue element, of the tiredness of examiners, students, and patients, specifically for patients. If they are being examined, there is a tendency they will get tired soon. So do you have backup patients available, standardized patients available, and are they trained to portray these signs and symptoms and to behave in very similar fashions? The test conditions, the environments and logistics, as I talked before, should be very similar for all students across shifts, across days. And then one will also have to think of standard setting. And standard setting is a science, is a method to establish a credible, defensible, and acceptable passing score for examinations. So think of you have developed very good stations. They are representative of your outcomes and the curriculum. You have trained your examiners, you have trained your standardized patients. All the logistics are very wonderfully arranged. You have an excellent OSCE examination. However, your passing or failing criteria on a high stakes assessment is not appropriate. You end up making invalid decisions or inappropriate decisions. You may be failing students who should have passed, or you may be passing candidates who should have been remediated first before they are graduated. And hence, standard setting is also a very, very important step to ensure that you make valid decisions on these examinations. There are various standard setting methods available for us to choose from. One when go on the internet or read books, one comes across a lot of standard setting methods. We know that borderline standard setting methods, borderline group and borderline regression standard setting methods are very commonly used and are recommended to be used for objective structured clinical examinations. NGOF is another very popular standard setting method, which can be also used for OSCE examinations. Is slightly more uh, rigorous and resource intensive. So one can choose from various standard setting methods. And then there are two different categories of standard setting. One is compensatory and the other one is conjunctive. A compensatory standard is a standard which is set on the total test score. Suppose the passing score that comes using the standard setting method is a 60% pass score. So a compensatory standard would say if any candidate gets a 60% on the examination at the exam level across all stations will pass, and any student who gets lower than 60% will need remediation and help and take another test before the candidate is passed. So any combination of performance skills is acceptable. And this is also very commonly used and is okay to use specifically when you assess multiple skills on every station for higher level of candidates. However, I will share an example from my institution where for in the early years of undergraduate education, we assess different skills on different stations because these are early year students and they've just learned the clinical skills. So we have history taking stations, we have physical examination stations, we have counseling and communication stations. And when we reviewed, and this happened around 5 years ago, and what we did is we reviewed past 3 years data. And what we observed that there were a few students who had extremely good history taking and counseling and communication skills, however, were not good in physical examination skills. And what happened is they compensated for their poor or low physical examination skills by their good history taking skills, and they were able to pass. And the feedback we got from later years that many candidates who were entering into year 4 and year 5, close to their graduation in undergraduate, were not good in the physical examination skills. So for that, we had to move to conjunctive standard setting. And when you use conjunctive standard setting, it explicitly defines the stations or skills that the examinee must pass to pass the whole test. For example, now in our early years, the student must demonstrate satisfactory physical examination skills and satisfactory history taking skills independently before they can pass the examination. So it does not allow the examinee to compensate for relatively poor performance in one or more skills with others. And this is also entirely up to your departments and to your institutions to decide. What is the objective? What is the aim of that assessment? What are you trying to do with that assessment or OSCE examination? And what kind of standard, compensatory or conjunctive, would better suit your objectives or your aim for that examination? Now let us move on to, once the OSCEs are done, and now we have the scores available with us, what can we now do after the OSCE examination to ensure and enhance the validity and reliability of decisions? We can use psychometrics, we can use statistics based on the scores. The simplest ones are the descriptive statistics, and we all are aware, the mean scores, the median scores, and the standard deviation. We can see the number of passing and failing students on each station and on the OSCE examination. We can run a reliability analysis. Cronbach alpha is very commonly used. It is critiqued though for its relevance to OSCE examinations. However, it is quite commonly used and is a fairly good indicator of reliability of scores. And then we have standard error of measurement. Let's talk very briefly on each of these. Let us talk of descriptive statistics. For example, the mean scores. It can also be thought of as the difficulty index of each station. So if there are high mean scores on stations, which means either the students knew it very well, or it was very easy, or one of those essential skills or problems which were very well taught and very well learned and practiced by the students. So when I was doing my undergraduate medicine, we were taught by our teachers as to not to rely on the laboratory reports only. We were taught and mentored and groomed to treat the patient and not the lab reports. And this is what I tell my staff and my team, and when I do such sessions and workshops, do not only rely on psychometric indices, do not only rely on statistics. You have to also think of the patient. You also, which means here, you also have to think of your stations, of the tasks, of the content. So with your assessment experts and psychometric experts and statisticians, you also need your clinicians and faculty and content experts. And then you will be able to make much more appropriate decisions. And this is an example. Unless and until you know if this was an essential station or a very easy station, you would not be able to say what is going on if you have very high mean scores on any station, or vice versa, if you have very low scores. Was it not relevant? Was it not taught? Was it really a difficult skill and you were expecting lower scores? The content experts, the clinicians, and the faculty will be able to tell you. The statisticians or psychometricians will just say these are abnormally high values and these are abnormally low values, which one does not or rarely expect on these examinations. And the standard deviation will give you the spread of scores. Was that station able to discriminate and differentiate between high scorers and low scorers? A high mean score could also mean a very lenient examiner. A low mean score on that station would also mean a very stringent or a hawk examiner. So one will have to create a true and holistic picture and should do a holistic assessment where you have your content experts, your clinical faculty, your exam developers and coordinators, and your statisticians available to make these decisions and to make this analysis and interpretations as to what happened in the examination. And then make decisions what are required. For reliability, you can run Cronbach's alpha on each station and on the examination. Cronbach alpha, as we all would know, range from 0 to 1. And 1 is an ideal reliability or Cronbach alpha, which means that there is no error, a theoretical concept. And based on OSCEs, because these are very complex assessments, we know there are a lot of players involved, a lot of variables involved, which may bring error or variations. We talked about standardized patients, we talked about examiners, and then of course the candidates and the task. Because of this complexity, a reliability or Cronbach alpha of at least 0.7 is acceptable as good enough for OSCEs. We also have to be aware that the reliability analysis, the value of Cronbach alpha would increase with increase in the number of students and would also increase with increase in the number of stations and items. A very high value of Cronbach alpha may also indicate redundancy of items or stations. When you tend to measure similar things, the reliability would go very high. So one has to be very, very careful as to how do we interpret Cronbach alpha. Standard error of measurement is converting your reliability in your units of scores. So many faculty would then ask me or would come to you and ask, what does a reliability of 0.7 or 0.65 or zero point 0.9 means? It is very difficult to explain it to them. However, when you convert your reliability into standard error, it comes in the unit of your scores, probably in percentages. And it is then easier to interpret and compensate because one would then know what is the amount of error in your scores. And when you will read the literature, it is suggested that for high stakes assessment, you can add certain standard error of measurement to your pass mark to maximize patient safety, to make the criteria more stringent, to make sure that due to the error and lower reliability of your scores in your exam, you do not graduate or pass out any doctors or physicians which are not safe yet. They need more training, they need more support and remediation and reassessment. For low stakes assessment, you can be on the student side. You can be more student centered. You don't want to penalize students because of your own error. Because of lower reliability or error, you don't unnecessarily want to hold students back. And what you can do is you may subtract the standard error from your pass mark to ensure that students do not unnecessarily fail due to any error in our scores. And this is how we may decide to use the standard error of measurements in high stakes or low stakes assessments. This brings us to the end of the session. Of course, we will have a lot of opportunity to interact and discuss if you have any further queries or questions. And my email address is also shown on the screen. If you have any further questions, please feel free to contact me later. Thank you. Over to you, Tabassum.
Thank you so much, Dr. Naveed, for a very informative presentation. And the participants, the attendees have been appreciating the information that is being provided
Thank you so much.
in
Very
your
nice
presentation.
presentation.
Yeah, so there are questions coming in. I would pose these questions one by one to you so that you're able to respond to them. The first question is related to the objectivity. Uh, the question is, in regards to objectivity, there is a big discussion on the field that subjectivity of expert is acceptable. So, what do you think regarding the subjectivity of experts?
This is a very good question. Uh, there has been a lot of debate happening in the literature, and there are studies which have now proved that reliance on the clinical faculty's expertise is good enough. However, I would say one will have to decide and come up with a very appropriate balance as far as the reliance on the clinical faculty's experience and judgment is considered. When we use the term subjectivity, probably there is a slightly negative connotation attached to it. It comes under biasness, and that is what we want to avoid. The better term, of course, is to rely on content experts' judgment based on their expert experience and expertise. When we read, and I will use the concept from the standard setting science, when we use standard setting and we read the literature on standard setting, they say good judgment will come from clinical faculty who have around 5 years, 3 to 5 years of experience in teaching and learning and in assessing the same content for the same level of students. So this is how they define having enough experience. And for an OSCE examination, I think any institution or department or for any examination, one can judge and decide as to how much experience examiners are we getting. We know for many of our examinations in my institutions, we struggle to get 14 or 16 experienced examiners, specifically for certain specialized fields. We do not have enough clinical faculty, for example, in ophthalmology. right? Or in psychiatry. So we may have to rely on clinical faculty which had not been so much experienced or not so much involved in clinical teaching, or which are relatively new examiners. Um, so then we will have to have more clearly laid out assessment criteria. So I would say, depending upon your resources, depending upon the kind of expertise you have in your institution available for the examination, we can always make a very appropriate balance as to how much reliance we will give. We will keep on faculty examiners' judgments as to how will they will score and assess the candidates, and how much criteria do we have to lay down. um, we lay down very specific scoring criteria. I would say very specific tasks, not the scoring criteria. There's a rating scale. However, the tasks are very clearly laid down. It also helps standardization so that the examiner is expecting very similar steps from all students. And if there are multiple examiners involved, if there are multiple circuits, multiple shifts, multiple days involved, then there are even higher chances that multiple examiners, be their own experts and experience, they might expect different things from different students. They might have inter-rater differences, and one will have to avoid that to be fair. And hence, I will say this is a good question. There is a lot of literature available which says we can very confidently and reliably depend upon the experts' judgments. There are studies which says even using global scales, there were equally good or even better judgments involved, scores involved, as compared to very stepwise, objective, structured assessment criteria. I would say it will depend upon your resources, how many experts are available, are usually available for your examinations, and then how many circuits, shifts, or days do you have for your examinations. And regardless, make sure you have debriefing and briefing meetings, you have orientation sessions. If you are using multiple examiners for similar circuits, even if they are experienced, make sure you have meetings with them to make sure that they have very similar expectations and very similar understanding as to what is expected and what needs to be assessed. Thank you.
Thank you, Dr. Naveed, for a very elaborative response. The next question is related to the time for each station. How many minutes you use for multi-skill OSCE, like history taking examination, in the same station?
Right. This is again a good question. Uh, for my institution at the Aga Khan University, the time of the station will vary from 6 minutes to 10 minutes, I would say. There are certain examinations for early year students. For example, from years 1 to 3, we may have six-minute stations, very specific tasks, either history taking or examination. However, as we move up, as we move higher in the grades, there can be even at 10-minute stations. However, when you will read the literature, you will even find stations as long as 14 minutes, 16 minutes. There are rare instances where there are 20 or 24-minute stations as well, depending upon the task. However, the key is that what needs to be assessed, uh, what will be assessed on all or most stations, the level of the learners, of course, and if these are multi-skills or single-skill stations. I
Yeah,
hope this
and
answers. Yes.
yeah, and other question again is related to very similar to what this question was. It says that how many rest stations there should be in a 16 station OSCE setup.
Um, Again, it depends upon the number of students, because sometimes you have to sequestrate and make the students go through the OSCE station. So that is one variable that comes into account. The other variable is the fatigue element. Um, um, so you have to give rest stations to your students as well. We usually keep one or two rest stations in a 14 and 16 station OSCE. That has been the practice at our institution, and I think this has worked well for us.
Yeah. So now the question is related to the performance of the students in a circuit. So what do you do when one candidate does a procedure but does it wrongly and not up to the mark, and another student does it very much up to the mark, while the third one completely ignores? Should they not be awarded 1 and point 0.5 and 0 marks? So this is what we tried once in Dundee in general surgery and it works. So what is your opinion?
Yes. So when I say using a rating scale, this is exactly what I meant. Um, you should have so that's the difference between a checklist and a rating scale. So a checklist is done, not done. You will just have a tick or no tick, or you will have a tick on not done or done. You will not be able to assess and gauge the quality of performance or the level of skills or competence of the candidate. When you move from this 2 point scale, done and not done, to a multiple point scale, and you have referred a 3 point scale, which is not done, partially done, and done well, a 0, a 0.5, and 1, it works well. However, the literature says, and if you read psychometric evidence and psychometric research studies, they inform us that a 7 point rating scale is an ideal one, which means a 0 to a 6 point scale. However, sometimes it is tedious, it is rigorous, and hence, in most cases, I've seen and I would recommend moving to a 5 point rating scale. However, this would entail then developing your faculty and making sure your examiners understand how to use what will a 2 mean and what will a 4 mean in a 5 point rating scale. And starting with a 3 point rating scale, which is a 0, 0.5, and 1, or not done, partially done, and done well, is a good way of starting moving away from done, not done checklists and moving towards a rating scale. So this was a good step, and I completely agree. And this is what I would have expected, that this would have helped you. I would say gradually move to a 5 point rating scale, which may help you differentiate and discriminate among students even better. Tabassum?
Yes, so now more questions are coming in, and the questions are related to, performing an online OSCE or virtual OSCE. So any way to perform OSCE virtually that you would suggest?
Yes, and specifically, I was expecting this question to happen. I had left this for the Q&A session and not included in my presentation. I knew this would come.
Yeah.
See, we all know, we all are facing educational crisis during COVID pandemic. And a lot of questions, a lot of discussions, a lot of debate is happening around the world in different fora, in different blogs. Some very recent new literature has also started to come in with regards to virtual OSCEs and digital OSCEs. There are various ways of conducting OSCEs during this pandemic and making sure that we comply with all the SOPs and all the guidelines. One is a completely digital OSCE, and it has its limitation. You will be probably able to very nicely assess and very appropriately assess history taking skills, counseling skills, and communication skills. You can use laboratory tests and x-rays and your radiograms and radiographs to assess students, question them on their clinical reasoning, on the decision making, on the management skills, which can of course be done in a written paper, don't get me wrong, but these can be very good stations. You can make very good stations where you can assess all these skills. Regarding clinical skills, I was going through the literature, and I also had discussions with my colleagues all around the world. Multiple things have been tried. Um, One is using very low, medium dummies available. So using a pillow to demonstrate suturing skills, using members of your family with their consent, of course, to demonstrate certain examination skills, or just elaborating upon how will you do certain steps. Of course, these all have their own limitations. If you have good clinical skills lab, you can schedule your students with all the precautionary guidelines and assess their physical examination and procedural skills using those mannequins, and do all the clinical skills such as history taking and communication and counseling using a digital or a virtual OSCE online. You can also have a specific group of your standardized patients from your bank which are COVID tested. The examiner can be seated at a distance or through a one-way mirror or a glass if you have a good clinical skills lab. The, your standardized patients are using from your pool if they are COVID tested. Of course, there are costs involved, there are risks involved. So there is a complete spectrum available which one can think of and try and implement based on the resources available and what kind of risks and limitations one is willing to take as far as the limitation of the exam and as far as risking, of course, the health of your patients, your examiners, and your students. What kind of exam is it? Is it a very high stake examination? Is it very essential to um, uh, administer the exam at this moment in time? Can it be delayed for some better times to happen? Can it go virtually with all the limitations? So all these are the questions to think of, and I think these are the different levels of OSCEs, a virtual, a hybrid OSCE, which you can think of to administer. Tabassum?
Yes, thank you. Now, other question is related to minimizing the fatigue level of examiners, because of, there are many number of students who are taking the OSCE at one point in time. So how can we decrease the fatigue level of the examiners for large setup?
Okay. What we do is we try and administer the OSCE either in multiple circuits. So there may be two parallel circuits happening. Of course, for that to happen, you will need twice the number of patients or mannequins or your examiners, which is difficult to arrange, or have multiple shifts, a morning and afternoon shift, or have a single shift and let the patient and the examiner take breaks and bring in another examiner and another standardized patient. For any of these to happen, training and standardization becomes much more important, because then you would require, and you must ensure that these multiple examiners and multiple patients on one station assessing the similar task is trained and standardized and behaves very, very similarly and scores very, very similarly. Um, or one can always have a 20-minute or half an hour break, give break to all patients and examiners, and then restart the OSCE again in a similar circuit. So you will have the similar examiner and similar patient. And this break is also a good opportunity where they can take break for 20 minutes and again a briefing meeting for five minutes to remind them of the task, to let them go through uh, 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 their instructions. The SP can go through their instructions, the examiner can go through the checklist, and then restart again. So there are multiple ways of avoiding fatigue. Fatigue is much more important for patients than examiners. I will give you an example of two stations where, for example, one, the patient is using an ophthalmoscope or otolaryngoscope, or the patient is taking ECG using ECG leads. This is much more difficult for the patients, and for such stations, you will have to much more frequently change your patients as compared to your other stations. So one has to be watchful as to the kind of task being assessed and the role of the standardized or simulated patients and the fatigue they will get with time. And one will have to be ethical as well. Not only think of fatigue, we'll have to think of being ethical and treating them very fairly. Tabassu?
Yeah, thank you, Naveed. And I'll just like to share our experience also when we were using and conducting OSCEs in medicine, where patients, where we do used to have patients from hospitals. They were real patients, and at times, they were not giving the medication, so we had to send them back. So these kind of issues are there, and we have to cater to these kind of issues, that we use stable patients, and as you said very rightly, that it has to be an ethical practice. So this is very important. Another question is related again to the same kind of response that you have given, that how frequent do we have to train the examiners?
The more you do, the less it is, believe me. Uh, um, they will have to be trained, and then there has to be refreshers. Uh, I will give you an example of the International MRC GP exam. Regardless of the experience of the examiners, regardless of the training, and regardless how well they have been doing in the previous examinations, every morning, early morning, 7 o'clock, there is a session, examiner refresher session, where all the examiners would come. Every morning means every morning of the exam. So if it's a 5-day exam or a 7-day exam, all examiners will report 7 o'clock in the morning, and they will be shown a performance on 2 different OSCE stations on the video from our previous examinations. They will all have the scoring sheet with them. They will all score, and then we then discuss and ask them, what did you score on each item, on each task, on each step, and why did you do so? So that there is a refresher and a briefing meeting every morning of the exam on 2 stations at least. So the more you do, the less it is, believe me, for your patients and for your examiners. What I recommend is a gradual recruitment cycle for your examiners. You will have to develop them first, then you will have to make them do the assessment with senior examiners. Don't rely solely on them on high stakes assessment. Keep them as a backup examiner, so you'll have 2 examiners on those stations ideally. And then once you are confident enough they are marking appropriately, then you can make them mark independently. So with initial training, you have to ensure that there are refreshers, and the examiners keep on getting the feedback, the kind of scoring they have been doing, if they have been too lenient, if they have been too stringent. So it's a continuous cycle. One cannot rely that they have been trained and now they're experienced and nothing needs to be done more. This cannot happen. Tabassum?
Thank you. The other question is, is very similar that we always observe, and it's a very practical question. Faculty who themselves has obtained high marks in their exams usually, they don't give marks to the students, and they behave like hawks to the students. So, how to avoid this bias?
See, the first and foremost task is training, making them understand what is expected, what is the level of the learner. And when you do this standardization workshops or retreats, as I had explained, you make multiple examiners sit together, get your students perform in front of them, or do a video shoot of your students performing on different tasks, show them the video and ask them to score. And we know we all function in bell curves. We all are normally distributed. So most of your examiners in that retreat or workshop or a briefing session will mark appropriately. There will be some stringent low scorers and there will be some high scorers, very lenient examiners. And then when they will realize, when they will work with others, It also reduces the burden on you as an assessment expert or the exam coordinator, that you have to tell the faculty and make them understand that they are lenient or stringent markers. When they see majority of the others marking in a similar appropriate manner, they themselves will receive this feedback if they are too stringent or too lenient. So this is one way of handling them. The other way is, um, there can be one station which can be difficult. There can be one station which can be very easy. So even if I am a good examiner, I can give very high scores on one of the stations in my lifetime as an examiner, or in a few stations, and very low scores on a few stations in my lifetime as an examiner. However, if you will determine my score across exams in which I've been an examiner, that will be an appropriate representative indicator of me as an examiner. So what we do for MRCGP international exam, and Tabassum, what we now plan to do for AKU, we will keep a record of the scores of examiners across stations. So if me as an examiner have been there for the previous 8 exams and on 8 different stations, which may be difficult, moderate, and easy. And if my mean score across that 8 exams is too low, means no matter what, I'm a stringent examiner. If my mean score is very high, irrespective, I'm a very lenient examiner. So this is also one of the method where you can give back as an indicator to your examiners. See, this is how you have been marking, irrespective of the station, irrespective of the level of the student, irrespective of the skill you were assessing, you have been too lenient or too stringent. So you also get some very objective evidence to give back to your examiners to show. Thank you.
Yeah, and the feedback has to be provided to that particular faculty as well. Yeah, thank you, Naveed. So very important and pertinent questions are coming in, and it's very difficult for me to follow the questions that are coming. There are a couple of questions which are related to simulated patients, and they're talking about whether they can use senior students as standardized patients, especially for the early years. And the other thing is that how can you bank the OSCE? So what is your experience of banking the OSCEs?
I really didn't get the second part. Is it banking the
Yeah,
OSCEs?
banking of OSCE,
Okay,
OSCE
okay, right.
stations. Yeah. So the first part is like, related to standardized patients, if they can use senior students for early year OSCE. And the
Yes.
second part is related to the banking.
There is no black and white yes and no answer to this using senior students. Of course, you may, and you can choose to. There are various aspects one will have to take care of. The first and foremost is to be very, very ethical. You will have to make sure that your senior students volunteer, they are willing, they have signed the consent form, and then you will have to keep on getting feedback from them if they feel comfortable enough to do this task. Um, if when you read the literature, you will also come across peer-assisted OSCEs. So these are OSCEs organized by students. Their peers will become the patients, their peers will become, the senior peers will become the examiners, and they will assess each others, will give them feedback. So yes, you can always use your senior students or your fellows or your residents as your standardized patients. So first you have to be ethical, make sure they volunteer, and then they are trained enough to perform in a standardized manner, in an appropriate manner, specifically for high stakes OSCEs. Um, and item banking, yes, there are some very good item banking softwares available, or you can have your own database. You can actually develop your in-house database if you have IT expertise available. So we bank OSCEs very similar to we bank our MCQs or short answer and essay questions. We have the attribute sheet. We bank them based on the learning objective, the tasks, the clinical problem, the difficulty level. We bank the instructions to the candidates, the instructions to the staff, to the assessors, to the examiners, the instructions to the standardized patients, and we also bank the rating scale or the scoring criteria with any other material which can be banked, such as will it require a lab report or a radiograph or anything else. Everything is banked in an electronic database, which then also makes it easier to retrieve and also to bank the performance data, how the OSCEs have been performing, what have been the reliability and mean scores, to make sure that when we go and develop an examination, we take out stations which are content representative and have appropriate psychometric analysis. Tabassum?
Yeah. Since you have talked about different methods of standard setting, now the question is related to, in your opinion, what is the best way of setting the cutoff score?
Again, I would say this depends upon the expertise and the resources. We know borderline regression method based on evidence is now considered to be the most appropriate method, I would say, to be used for OSCEs. A relatively statistically easier method is the borderline group method, because borderline linear regression uses a relatively higher level of statistics and psychometrics. So one can even go for a borderline group method. We at AKU use NGOF method, and this works well for us. However, we have also done one study which says that borderline linear regression would be better than NGOF. However, we believe that our examiners are now not trained enough, are not developed enough to be moved to borderline regression. And this example I'm giving to you because it is also important that you will have to have your resources, your experts and expertise ready before you embark upon any journey. And the most recent literature which is coming out of standard setting says you cannot rely on one standard setting method. You have to now follow at least two standard setting methods, and then a committee should sit and decide upon the most appropriate passing score based on what kind of evidence do you get from students' performance and from two or more standard setting methods. So this is the way to go. When you start, please start off as a pilot and see first, how does it work for you? You don't want to start something and pass everybody unfairly or fail everybody unfairly before you have learned the skill to apply the standard setting, the science and method of standard setting good enough, and make sure it is working for your setting and for your exams. Thank you.
Yeah, so there's one last question. With this, I'll then conclude the session. The question is related to, the two methods that you have mentioned, compensatory and conjunction method. So what will be your preferred method? Uh,
Right. See, for early clinical year students, for us, based on evidence, because remember I said we did a study. We did a study of the past 3 years data 5 years ago. And what we saw that we were passing students in years 1, 2, and 3. We have a 5-year undergraduate program. We were passing students in year 1, 2, and 3 because they had good history taking and counseling skills. They were good talkers. They were good speakers. However, they were failing many or all physical examination stations. And this we did a study because we were getting feedback from our year 4 and year 5 clinical faculty that these students they are getting are not good enough. We as an institution initiate teaching and learning of clinical skills right from year 1, even when they are studying basic sciences. There is an OSCE examination in year 1 and year 2 as well, even before they start going into their clinics and clerkships. And for us, when we were getting this feedback that the students do not know physical examination well, when they enter year 4, which they have been learning from the previous 3 years, was a bit of a concern. So we went back into the data. We did this evaluation study. And we found that the students were managing to pass because they were good history takers and they were good in counseling. They were failing many physical examination students. So for us, we found in the early clinical years, the compensatory standard did not work appropriately for us. We had to introduce a conjunctive standard, making sure the student passes history taking stations separately as a separate cutoff score and physical examination stations set separately. For later years, for year 4 and year 5, we realized that this is not a good strategy because many stations are multi-skilled. On one station, we are assessing history taking and physical examination, or physical examination and counseling, or all three of them. So for our later years, this may not be a good idea. So it depends upon what is your purpose and your aim of the examination and what will suit you well. Again, when you change any policy, when you introduce anything new, please make sure you introduce it as a pilot. First, look at the consequences as to the number of passing and failing students, if it is going a good job, and then you can implement it. And before you implement it, your students should also be aware of your passing and failing criteria. We piloted for around 2 years. And in the third year, we were forced to pilot because the students were informed. We had informed the students, but it was not printed in the student booklet that we will follow a conjunctive standard. And just because it was not there in the student's booklet, we had to pilot the third year as well and not implement it. So one will have to take care of all these elements before one go and implement anything new. Thank you.
Thank you so much, Dr. Naveed. I think this has been a very wonderful presentation and very elaborative and very practical, responses that you have given to the questions. And I am pretty sure that the attendees will benefit from your experience as well and the experiences that you have shared with us. With this, I thank you. Thank you for your time, and thank you everyone who have attended this webinar and and have put in their questions. With this, I would now like to hand over to Shifa. Shifa, please.
Thank you so much. And thank you, Dr. Naveed. And inshallah, we hope to have you back again very soon for another lecture. And with that, if I could please invite Dr. Shabi Zaidi, the Chancellor of Sadiq International University. He has some slides and a special presentation. So please uh, let me share the slides and you can begin.
Thank you. Well, let me begin by thanking Naveed for a wonderful talk. It is not just theory, it was embedded with a practical experience at every step, and you answered the questions showing the expertise, because you can differentiate between a theoretician and a practical person by listening to the person who's talking. It was marvelous. Thoroughly enjoyed it and learned a great deal. So thank you again, and thank you, Tabassum. So let's start with what we plan to do. Right at the outset, I would say that we started this campaign of educating through digital technology and e-learning, distance learning. The concept came to me a couple of years ago. We did an experiment with Medics International Virtual University, but because of certain reasons, deficiencies in medical technology, information technology, etc., I had to stop. So on 6th of March this year, after the COVID hit us, and I was made almost redundant from the NHS job, we thought that the best way to use this time is to disseminate knowledge by gathering the experts from all over the world. So we started working on a virtual university platform, and we gathered people starting with about 5 or 10 people on 6th of March. I think it was the first time we had a meeting. April, we started working more aggressively. In May, on 17th of May, Medics International had a massive global webinar series, 6 to 10 hours, and I gave a talk about it. And I inaugurated the online courses through Sadiq International Virtual University with a lecture by an expert called Professor Larijani, who's a Master of Ethics. He's from Tehran University of Medical Sciences. That was the beginning. In the month of June, we had collaboration with various agencies like the Global Health Academy of Edinburgh and other people who participated in conducting these courses. but that was in May actually, and May and June maybe a few weeks. So we had about 8 to 10 webinars in those a few months. Then we started doing a regular series. And could I have the next slide, please? Then we started working how to establish, and since then we have run 18 webinars, 5 workshops in the last 6 to 8 months, more than 800 unique registered participants. They're not participants of ordinary stature, they're professors, chancellors, vice chancellors, deans, facilitators, medical educators, and experts. So if you look at the number of people who have benefited with this, I would say that if you multiply each one of them as a downstream flow with at least 200 people, because each one is a medical educator himself, so they will educate more people in their faculties, universities, right across the world. Would you believe it that it's gone on viral, starting with just from London or USA or Toronto? It's become, I think about 10 or 15 countries have participated in these educations things. There are highly skilled people who came to assist, help, and guide us through these things. There were top-notch professors from different countries. The moderators were from different countries also before Tabassum took over. And we had a fantastic chat group. So now we're starting to turn a page or can turn a corner from medical education and faculty enhancement program towards clinical side as well, because a lot of people want us telemedicine and telehealth to be a part of this activity. Next, please. So what we pledge is that we want to continue, or we pledge to continue providing high level of medical webinars in not just medical education, but also medicine and surgery, as well as allied specialties. Next, please. So we want to start with different webinars, starting again in January. Hopefully we'll take a break around this time, the festive period. And after the new year, we'll start working towards a series of programs. Tabassum, along with the scientific committee comprising of 4 or 5 people, will organize it. We'll also start short and long-term courses like certification courses going maybe towards masters and so forth. We are already negotiating with different universities for collaborative programs. Next, please. It is expected that we'll have weekly webinars like we've been doing even now, and probably on a Saturday or Sunday. At least Saturday is definite, 11 a.m. time. Shifa organizes, runs them smoothly, and Mubashir helps with the IT. And of course, Tabassum is moderating, and then we have backup services from Mulazim Bukhari and all the other people. Next, please. Now, we are hoping that we'll start these medicine, surgery, and allied specialty webinars and seminars. That is where we need expertise. So we'll start with carefully selected topics in medicine and different things like pulmonology, respiratory physiology, asthma, COVID-related problems, whatever. Each topic has to be for 20 to 30 minutes. That is from the point of facilitator or clinician. Then there has to be interactive programs like we did just now. Interactive 15 to 20 minutes program, question and answer. Those questions which cannot be answered on the spot will be put on the web page and they can be answered later on by the speaker. What we need is at least 2 to 3 or maybe 4 presentations from each professor or teacher or scholar to come forward and fill us in through the courtesy of IT service that we have. And Shifa will tell you the webpage also. Come forward, please help us so that knowledge can be disseminated across the borders, because transcendence of knowledge is the outcome, or that is the only silver lining in the gray cloud or the black cloud of COVID that we can see. Because you've crossed the borders, you can disseminate knowledge wherever you want, whenever you want. Next, please. Now, this is just an illustration that Mubashir has kindly developed, that we can have these different topics. You can see some topics which are clinical topics. Some are ethics related, some are facts and fictions of COVID related, optimizing treatment and renal failure. So different topics from multiple specialties can come forward. Now, we are blessed in Medicine International with hundreds of top-class clinicians in American universities, Canadian universities, British universities, India, Pakistan, Iraq, Malaysia, and all of us. All are welcome. Saudi Arabia, anywhere. Please come forward. We look forward to gaining knowledge from you. So choose the topic, let us know, and how would you like to present? And of course, we'll move forward and organize it. Next, please. We'll also start soon, and Mubashir is already working on it, sitting in Malaysia, on Coursera-like courses, which means courses on clinical sciences, medical technology, paramedics, nursing care, what have you. Sky's the limit. The courses will be available like Coursera anytime, anywhere, and you can access them. And the platform is being developed at the moment. Mubashir is working with his team, LMS system, Moodle and Moose, and everything is being worked out. Next, please. So all these services will be available to you. This is the structure that our experts have devised, that we do some learning exercises. We'll have course learning, groups of, you can read it yourself, and I'll put it on the web page. There'll be short courses, probably starting with 2 lectures a week and 3 months courses. They divide into semester. Then we have question answer sessions. Then we'll have assessment accordingly, weekly exams, summative and formative, both kinds of exams. And Tabassum, with the help of now, of course, we have Naveed and many other people, and we have experts from the UK, like John Sanders is there to help us out, and Mary is there. She promised to help us out. And of course, Sholay is always there in the background. They're expert teachers, and of course, many people are coming forward. Will Trudy, lots of people. They're all there. Of course, my friend Robin Blair, and I will try to get Ronald Hardin as well. I've known him for years, so hopefully one day he'll oblige. So these are the things that we want to do in 21. So we're closing one chapter in a way of regular webinars, moving on to more like interactive courses, etc., etc. Next, please. Next. So what is needed, and this is where I appeal to you, all the teachers, facilitators, clinicians, physicians right across the world, please come forward. Give us 3 or 4 topics of your choice in the next year, 2021, and then we'll start with develop them into packages, into short and long courses, certification courses to begin with, and of course we can go on to higher courses also. I mean, like I said, sky's the limit. Come forward, help us, because nothing can beat the quality of service that you can provide through your expertise, your knowledge, and disseminate it wherever you can, because what you can do now is more like it is for your later life hereafter, where God will reward you with this, with the service that you're doing to mankind. Our motto, the motto of Sadiq International University, is very simple: enter to learn, go out to serve mankind, humanity, through health and education. Next, please. And this is where I'd like to thank my team. People who have been, an amazing number of people have come forward. Mulazim Bukhari is the backbone of this entire project. Tabassum Zahra is the moderator. Sholay, really, she couldn't attend today. She's from Tehran University. She has been monumental, phenomenal in guiding, advising, helping, getting academicians from across the world to us. Shahid Hassan is my old student. He's in Malaysia, the professor of medical education, extremely powerful speaker, very potent. He did wonderful workshops. He's not well at the moment, but hopefully he will join us again from January onwards. Mubashir Iftikhar is he's the backbone, literally, I mean, like the very spine, the person who's responsible for all the IT services. Without IT, you can't do anything, of course. Hasnan Zafar helped us with moderation and IT service in his department. And of course, IMI headquarters, particularly Wajir Rizvi, who is the owner, founder, the first president and founder of IMI. And then Arshad Karim, who is the chairman, academic council. Then Shifa Abbas, of course, she is the moderator, organizer, conductor. She does everything, puts everything on the webpage. Without her, we could not have done anything. So no one to thank all. Then, of course, faculty from Malaysia, from Iran, Pakistan, India, UK, Australia, South Africa, and many other countries. Thank you, thank you, thank you. God bless you all. You have done wonderful work. We remain in debt for you forever. I tell you, Sadiq International and Medicine International will always be grateful to you for helping us out in this project for the welfare of mankind. The only objective that we have is to gather information and disseminate it across the world. Next, please. So that is a clap for all of you who have helped us in organizing this program. So 21 sees the new version of Sadiq International Virtual University. And of course, we'll continue to meet again. And then I'd like to say Season's greetings to you all, and hopefully 2021 will be a better year than 20 was. So thank you and God bless. And that is the end of my talk. Thank you, Shifa. Over to you.
Thank you so much. And so again, please feel free to join our WhatsApp group and take a look at our website, and we will begin to post for the next events coming shortly. Thank you and goodbye.
Thank you, everyone, and Happy New Year to all.
Thank you, and same to you.